Good morning. Before we begin today's session of the hearing, I would like to say that it was with great sadness that I and the other members of the inquiry team learned of the passing away of Molly Cuddihy. Ms. Cuddihy gave evidence to the inquiry in the first of our hearings in 2021. It was evident from that testimony that she was a young woman of great courage, great determination, and clear intelligence. Our thoughts are with her family today. Thank you. We will now proceed with today's hearing, which I think is the evidence of Professor Mike Stevens.
That's correct, Lord.
Right. Good morning. Good morning, Professor.
Good morning, I'm sorry.
Now, you have, of course, given evidence to the inquiry before, and you'll be broadly familiar with the way we proceed. But first of all, you are agreeable to take the oath.
I am.
Sitting where you are, can I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
I will tell the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Thank you, Professor.
Thank you very much.
Now, you're scheduled for today. I'm not sure how long your evidence will take. We will probably take a coffee break at 11:30, but if you want to take a break at any other stage, just give me an indication and we can do that.
Thank you.
Now, Mr. Connell.
Lies Lord. Good morning, Professor. Good morning. You've given evidence before, and I don't intend to go back over who you are and what your CV is. That's already in the documents that the inquiry has, and which participants will be familiar with. For the purposes of today, as a guide to moving through the topics, I'm proposing to look at one document as the base, which is what was described as a rebuttal of what we've been calling the HAD report, which you and your colleagues were asked to prepare. And we find that at bundle 44 at page 120. Just wait for it to come up on the screen.
That's volume 3.
Yep. No. Yeah. Error must be mine. Bear with me a second. Just trying to find it in a long list, I'm afraid.
We seem to have it on the screen.
Ah, it's good. We've got it. I'm obliged. No, just for the sake of formalities, I take it that that was a document to which you and your colleagues all contributed.
Yes, we did indeed.
But so far as this morning is concerned, Are you content to incorporate it as part of your evidence?
Absolutely.
Thank you. You were asked to produce this by the inquiry, and you duly obliged. And we'll just go through it. The document starts at page 123, perhaps logically, by setting out as background the role of the oversight board and the work, and then ultimately the case note review. And what you have done in this document, as I understand it, is to take the HAD report, look at certain parts of it, and then comment on it as you go through. Is that correct?
That's correct.
Now, am I right in understanding that you've had the opportunity of looking at some of the further material that's been produced since this was produced, such as further charts and so on?
Yes, I have.
And we'll come to that later. And I think you've also had an opportunity or taken the opportunity of listening to the evidence of Dr. Agrawal and also the evidence yesterday. Is that correct?
Yes, and Dr. Drumright.
Yeah. And Dr. Drummer. So all of the three HAD
Yes.
authors.
Yes.
And it's probably fair to say that some matters at least have moved on since this rebuttal has been prepared. Is that correct?
Yes, I mean, there is some substantial sections that have clearly changed in response to further analyses.
And that may allow us to move a little more quickly than might have been the case over some of these issues. Now, just going to the substance of the document in front of us, at page 124, you make what is in effect the first substantive point of what you might regard as criticism of the HAD report, which is that they don't discuss IPC at all, or hardly at all. Did you think that was an important point?
Absolutely. I think we felt it was an absolutely critical issue in relation to rates of infection, which was their principal focus.
Now, at this point of your report, what you're doing is in your introduction, picking up things that are in the HAD early stages rather than in the detailed chapters. And on page 125, near the foot of that page, you make a point about whether the precise route of transmission of an infection is usually established when there's been an investigation. You say it's almost never established. Is that right?
Yes, I think I think there are many opportunities for a route of transmission to the patient, and it would be difficult to prove without any doubt which that route is. I mean, one can make certain assumptions in the clinical care of patients, and particularly in the care of the patients we're discussing, where they, and I think we talk about this both here and possibly later in our document, that most, but not necessarily all, of the patients will have indwelling central venous lines, which are manipulated frequently. They often undergo a number of other invasive procedures. So there are portals of entry, but there are also routes of transmission from the multiple exposures to other people and to other things in their environment.
Yeah, you are quite correct that you list some of these perhaps in detail later in your response. Is that right? Now, perhaps the sharpest, I can suggest one of the sharpest points of departure identified in your early stage discussion of this comes on the next page, where you quote part of the executive summary of the HAD report, where it says that attributing the source of the bloodstream infection pathogen to the built environment can only be shown if the strains identified are indistinguishable, a source is present, a route of transmission, and the portal of entry are identified. Now, your response to that is simply to say that's not true.
Well, it's not consistent with the standard infection prevention control definition, I think. And it really all hinges around the issue of strains being identified as indistinguishable, and the definition of the identification of the route of transmission and the portal of entry. So there's rather more precision in this statement than I think exists in real life.
Now, I understand from your earlier answer that routes of transmission and possible points of entry are often, a number of these are identified in an individual patient case. Would that be correct?
Yes, I think that's the case.
Rather than be able to say, well, it's X, which has
Yes.
gone in via Y, you may have A, B, C, D, E, F, G. Is that the kind of picture you're trying to paint?
Yes, I mean, I think I think it would be very difficult to say unless testing is undertaken to prove the situation. For example, that an infection was acquired from a shower trap, that a portal of entry was when a central venous line was accessed on a particular occasion on a particular day. But nevertheless, all these are risks within the environment of the patient, and the whole point about infection prevention control is an awareness of those risks and attempts therefore to mitigate them.
And then your conclusion is that you can attribute quite reasonably the origin of an infection to a source if the data is consistent with that being the case.
Well, I think you can impute that by demonstrating the classical association of time, place, and person, which is the principle behind which we undertook our work.
Does something perhaps turn on how you understand the word attributing? And I'm thinking it in particularly under reference to strains being indistinguishable.
Yes, I mean, I suppose you're right, my lord, that it's the strength of the use of the word attributing, and I don't know whether perhaps attributing also imposes or includes an element of designation rather than certainty. I'm just not sure.
Mm-hmm. I mean, it occurs to me there might be a difference between imposing the criterion of 100% scientific certainty as opposed to clinical judgment. And when I use the word clinical judgment, I mean the sort of level of association which a clinician would regard as sufficient to proceed with his treatments or his attribution of causation. And that's maybe not very well said, but what I think maybe interested in exploring is whether whether clinicians always proceed only if they have scientific certainty as to, here we're talking about cause and effect.
I think it would be almost fair, my lord, to say that clinicians proceed very often without evidence of scientific certainty, in that one has to make judgments based on the information available to you at the time. And I suppose if I bring that back to the context of this matter, I would say that's exactly why hospitals hold multidisciplinary meetings like PAGs and IMTs to consider the weight of the evidence that would direct you to a supposition that a particular source was a likely cause of infection in this setting.
Thank you.
Well, can I come now to another point where you've picked up on something early in the HAD report and then sought to deal with it, which we find starting near the foot of the same page, page 126, where you pick up a statement that if the built environment poses an increased risk of infection, then this would manifest in an increased rate of infection. And you say, well, sounds intuitively correct, but you have a but there. Is that right?
Yes, I mean, I suppose I would summarize our position as this, that the expression of an increased risk of an infection to an individual is not equivalent to the identification of an increased rate of infection in the population from which they come. Now, that may sound a little semantic, but in essence, that a patient could be exposed to an increased risk of infection without that necessarily reflecting an increased number in an increased overall rate of infection, because one has to consider the individual circumstances of the patient. And I think this is a little bit of a theme in our rebuttal, that we undertook a process which was more, I suppose, holistic in terms of patient circumstance, whereas the HAD team undertook a review of changes in the rate of infection. And I think it's a difference in approach. And I suppose I would say that in a sense they're complementary, but merely because you don't see an increase in rate of infection doesn't exclude the possibility that there wasn't a risk of infection to an individual.
I think this is a point that has emerged, as you have gathered, on several occasions so far in discussion with others, that the exercise that the CNR did, which involved examining individual patient material, is not something that either this inquiry or indeed the HAD team were able to do because of the issue of, they weren't given that material to do that. Because on page 127 at the top, you sort of pick up the suggestion that, well, the CNR doesn't help. But do you think the fact that you were able to do individual patient examination in terms of data was something that was important to your work?
I think it was unquestionably important that simply, and perhaps I can distill it this way, simply looking at the date at which a patient got an infection, it doesn't tell you very much about the potential for the risk of that happening. Perhaps perhaps I'm not, well, I know I'm not being clear, but perhaps I could give an example. So it may be that a patient had been an inpatient for 7 weeks. And with a scenario we would have encountered in the case note review, a patient would have been continuously an inpatient for, say, 7 weeks, and then developed an infection. And our hypothesis was that it's much more likely that that infection arose from the experience of being in the inpatient environment than that the patient brought that infection in with them, and it suddenly popped up 7 weeks later. Now, on other occasions, a child would present to the emergency department of the daycare unit with evidence of an infection, but had not been in contact with the hospital environment for perhaps a couple of weeks. And so there's a different weighting, or there was a different weighting in our minds as to the nature of the potential for an environmental origin for that infection. I hope that's helpful.
No, thank you very much, Professor. So we find on page 127 the point that you've just made a moment ago about the increased risk of infection to an individual not being the same as an increased rate of infection in the population. Can I just ask you, I don't really want to get into a great debate about clustering, but can I just ask you about what you say in the next paragraph? Because you've put it in reasonably straightforward language, I would suggest. Can you just take us through what point you're trying to make in that paragraph there?
Okay, perhaps I could just quickly revise it. Yes, I mean, I think I think this paragraph actually reflects some of the exemplars we gave in the case note review, and where we're arguing essentially that to see sequential or several examples of the same infection, perhaps several examples of another infection, occurring within a relatively short, I mean, when I say short, I'm talking about a number of weeks or possibly a few months in the same environment, seem to us to be less likely to be what's the word I'm looking for, a coincidence, than to actually imply that there was some reason for the apparent clustering of these events in time and place.
You're dealing with that in the context of the proposition that the bloodstream infection might have been endogenously acquired. The way I read it was you were saying, well, what's the chance of all of these patients at the same time?
Yes, popping up with a gut
issue.
translocated or an infection from their skin or upper respiratory tract. Yes, I mean, I think I think you put that rather more clearly than I did. Thank you very much.
Thank you. Now, in the next section of your report, which started on page 128, you pick up on part of the HAD report which talks about listings of microorganisms and so on, and I'm not proposing to take you to that. On page 129, you have a heading, what is meant by an outbreak? Now, this is perhaps where the apparent requirement of HAD for genetically indistinct microorganisms changes the game completely, because if you very rarely get that, you wouldn't get an outbreak on their definition at all. Is that fair?
No, although I sense from both reading the report and hearing the responses of the authors that they recognise that to be the case, that there is a real world and there is the world of aspiration, and I believe that in time methodology and scientific technology will move on so that you may have almost the real-time ability to confirm genetic identity. But that's not the situation we find ourselves in today. But there's no doubt that methodology, I suspect, will come, and the world will look differently then.
And the definition of an outbreak that you used was the one from the National Infection Prevention Control Manual. Is that right?
Yes, I think our approach was consistent with that definition, and I think that's the standard to which infection prevention control teams work.
And the point you make, I think, on the next page is the one you've made earlier, that it's not always possible to identify the source. This is about the third paragraph on that page. Yeah. Either until later or sometimes at all. It's not, you may never know.
Well, I think the point we're making here, and I think it's a point that we have made more than once, is that if you're looking to link a patient sample to an environmental sample, you have to take the environmental samples in sufficient number and range to have the opportunity of identifying the link.
Well, I'll return to the needle in a haystack proposition that you mentioned later. just a little further on. I think later you make the point that root cause analysis, which is a particular approach to investigation, wasn't introduced in the Queen Elizabeth Hospital until relatively late on in the
Well, the end of
period we're looking at.
2019.
2019.
Yeah.
Thank you. Now, if we could move on from there, if we go to page 133, we then find you're picking up on chapters commenting on how your case note review dealt with certain bacterial species. And I think the way in which this rebuttal runs is you look quite carefully at Klebsiella, and then in less detail at some of the other organisms. Is that correct?
Yes, I mean, we decided that we would take a greater focus on Klebsiella. I think not merely because we thought it was a specific exemplar, but because Professor Hawkey and colleagues made the point, and I think it's justifiable. It's a difference in quantum, which is possibly a word we'll come back to. But they made the point that the majority of Klebsiella infections arise endogenously, and that they're not necessarily that frequently found in water supply. And I think what we wanted to do is to rehearse the fact, and referring to some of their own statements as well as other literature, that actually Klebsiella can be found in water and surfaces that have been in contact with water in the ward. And we're just really making the point that this is perhaps a little more complex than or a little more uncertain, perhaps, is what we were really trying to express, than the statement that might otherwise have been believed.
And in fairness to you, as you perhaps just illustrated, as you go through your rebuttal document, you do pick up on areas where there is agreement between the HAD authors and the CNR authors, and you.
Yes, I think there are. It comes back to what we said. Perhaps what we've tried to say, that there is perhaps not such a great distance between us, and that we've come at this from different perspectives.
And did I just say that because, as an example, we find on page 133 a statement lifted from the HAD report that it's important to maintain a balanced view, is just because bacteria of the same species can be found in sites that are not necessarily the source of the infection. And you say, good, we agree with that. That's the way we approached it.
Well, it certainly wasn't our starting point. I hope we were able to keep an open mind by looking at the sort of broader circumstances of the patient's situation.
And having produced another quotation from HAD, you then at the foot of that page say, well, this appears to agree that the hospital environment could be a source of that particular gram-negative bacteria.
Absolutely. I mean, I think what we were seeking to do was to slightly redress the balance from this being presented as an organism that largely was not found in the hospital environment as a cause of infection because it was endogenously acquired, to suggesting that there was perhaps a slightly greater risk of this organism being found in the hospital environment, and that it wasn't necessarily all endogenously acquired.
Would I be right in saying, I tried to explore this with Professor Hawkey yesterday, the topic of, the way I put it to him was to ask him what he saw as the purpose of chapter 3 of the HAD report. I'm not too sure how successful I was, but would I be right in saying that if one goes to chapter 3 and looking at your responses, if the question is it possible that the source of the various microorganisms which are listed in chapter 3, if the question is it possible that they might thrive and therefore in a water environment and therefore make the water environment a possible source of infection, there is no occasion in chapter 3 when the authors of the HAD report says this organism, which the CNR have assumed was a potential environmental source, cannot ever be found in the water environment. That's a rather clumsily put question. Is there any instance where on one side the authors of the HD report says this organism cannot come from the environment, and on the other side the authors of the CNR report say it can?
No, I don't
Mm.
believe that. I don't believe there is a clear divide at all. There are nuances,
Yes.
and there is a particular comment I think about Acinetobacter, which is and here I'm not a microbiologist, but I think there's a comment that this is an organism that quite likes surfaces that have dried after water exposure. And I think what some of the detail in this chapter does for us is it identifies that these are individual organisms. They exist within a general group labeled environmental and enteric, but they do have some nuance in terms of their behaviour. But I don't think it rules out any of them from. I don't think there's a fundamental disagreement.
Well, that's possibly a rather better way of putting it, because I couldn't actually identify an absolute a disagreement. Bearing in mind, as you say, there's nuances one way and the other.
Yeah, I mean, perhaps if I may be allowed just to extend my comment to say, and maybe Mr. Connell will take me there in a moment. It's just the absence of Mycobacterium chelonia in their consideration of what's environmental. It's a striking absence, and it remains to me unexplained as to why they chose not to do that. But there has been a lot of discussion, I know, about how you derive your list.
Well, I think all I need to do in light of the discussion you've just had, Professor, is just record, so again we can follow through the way this rebuttal has been prepared, that what you then do, having picked up on the fact that it's possible that there may be an environmental source or an environmental method of transmission, what you then do in the succeeding pages is you pick up on a number of publications which you were able to find, which say things like these are potential reservoirs of infection and similar material. Is that the way that next section follows?
Yes, I think we were keen really to reinforce our position that I mean, for example, I'm looking here at page 134. We just wanted to reinforce our position that that Enterobacter in this context is found in the environment. I don't think anyone would disagree with that, but it has been clearly identified as a source of infections in patients, and that you have to look quite hard to identify the source.
Yes. And you follow through a number of, I won't get to read through all of the extracts of material that you've put together, because they all say variations on the same theme. Is that correct?
I think that's correct.
And you pick up in particular, I think, on 135 and running on to 136, some comments from a working party, which Professor Hockey also participated, about how, in particular, gram-negative organisms may transmit and what the routes of transmission may be, and the possibility, at least, of water sources being involved.
Yes, I think the quotes are on the next page.
So 136
Thank you.
at the top. So we see there environmental screening should be considered when there's unexplained transmission of gram-negative organisms or a possible common source. Transmission from patient to patient is believed to be mainly via hands of staff, etc. Common environmental sources have been described. Water supply mentioned as a possibility, and so on. So you're picking up on more material in the literature, in this case partly authored by Professor Hockey, which at least raises the possibility of water sources being involved. Is that correct?
Yes, and I think underlying this is the theme that the infection prevention control measures are important in addressing these risks.
Yes. And you then pick up a comment near the foot of page 136 about sink traps and the presence of biofilm. The authors, the HAD authors, say that I think this is a quotation. Is this a quotation from the Hockey study, or is this a quotation from the HAD report? The one about sink traps?
The second to last paragraph on page 136 is, I think, a quotation of the text in the HAD report.
Yeah, that's the way I read it. Thank you. And so that the HAD author is saying that sink traps are sometimes seen as the most important source of gram-negative infections in wards with vulnerable patients. Would you agree with that?
Yes, I mean, I believe that to be the case, yeah. I mean, they are important, but so are a number of other things, clearly.
Yes, just so there seemed to be some misapprehension which perhaps lurked behind some of the discussions over the past few days, that you were saying that everything comes from the environment, but that wasn't the conclusion you were reaching, was it?
Well, it wasn't intended. When I reread some of the documents, I mean, it's important to have insights in retrospect, I suppose, and I recognize that in describing in the case note review that the majority of the cases were possibly related to the environment. What we were trying to articulate was, well, they are possibly related to the environment, but we're not saying that they are. And one or two people, I think not necessarily in the HAD report, but one or two people have picked up this percentage of, they say that 70% are possibly related to the environment, and so we're kind of implying that they are related to the environment. We haven't been able to prove it. That's not the truth. That's not the situation. That's not the message we intended to portray.
Well, just so we're clear, since we have you here, what was the message you were intending to portray?
Well, the message we were intending to portray was that we estimated at about 30%, thereabouts, of the infections that we investigated. We felt there was good reason to believe that on the balance of probabilities, they derive from the environment in which the patient had been treated.
And that was primarily from, let me just call it, from a water-related source, rather than the water, sink, traps, drains, whatever. Is that right?
Well, I think when you talk, and I think Professor Hockey had possibly made this point at some point in his report. But when you think about the patient environment, you do have to think about everything. You have to think about equipment. And of course, water affects equipment as well, because of course, most equipment is washed with water. Not all. You have to think about equipment. You have to think about pharmacy preparations. I mean, there's a clear example that has been discussed on many occasions about a cuprovidus infection in a patient in 2016, which wasn't part of the case note review, but nevertheless was a seminal case because it could be shown to be linked to the preparation of a pharmaceutical product. And so there are many things you have to think about in terms of the environment, but clearly water and water-related phenomena comes very high on that list of possibilities.
And you then go on in your rebuttal to pick up on some of the literature that was considered. I think you refer to a thing called Kisney-Gordon. I
Yes.
think I'm right in thinking that was rather than a study, it was a literature review of studies.
Well, it was a systematic review, and I think in the hierarchy of searching literature, systematic reviews are considered to be pretty high. And that's because there is a structured approach that one needs to undertake to do a systematic review. I mean, it's not just a casual label, it defines a methodology. And it means that if done properly, the authors have screened a number of publications to make sure that they only include ones that are of adequate standard to answer the question in hand. And so, we recognize that was, by nature of its methodology, and because it refers to, it's not just a single study, there's always a danger of taking conclusions from a single study because it may prove to be an exception. But a systematic review generally offers better quality evidence.
And this, I'm clear, because a layperson might not understand from my casual reference to a literature review the point that you're just making, that this is a particularly rigorous scientific review process that you've just described.
Yes, I mean, clearly, if done properly, and I believe this was a rigorous. Looking at the paper, I believe it was a rigorously undertaken process.
Yes. And what you've then gone on to do is pick up on a number of quotations from that review, largely around the possibilities of reservoirs of infection in a variety of sources. Is that right?
Yes, and I think at the end of this section, I think there's a comment that we make that we've slightly gone to town on this section in Klebsiella, because we're trying to establish the point, and what you see, the sections that follow this are much briefer because we don't rehearse the same principles.
Right. What you've done is yes, as you say, you've gone to town a bit on Klebsiella to show the point you're trying to make, and then you don't then repeat that at length in every other discussion.
No, but the general principles, I think, are applicable.
And how would you like to summarize the general principles that you're picking up here, just so we know what they
Well,
are?
I think just to go back to what we were discussing a moment ago, it's essentially to say that we recognize that infections do arise endogenously within patients who are already colonized with an infection within their gut, but there are also many possibilities for these infections to manifest through transmission from the environment. And perhaps one of the points that we haven't articulated particularly well, or we haven't been explicit about it, and it reflects something that Professor Hawkey talks about, which is talks about a colonized patient then colonizing another patient. To my mind, the transmission of an infection from a colonized patient to another patient actually represents a challenge for infection prevention control. And if a patient acquires an infection in the environment from another patient, then I see that as an environmental infection. if a patient brings infection with them in an organism in their gut with them into hospital. But the difficulty is we very rarely know that. Although very interestingly, I noticed in I think Miss Harvey Wood's witness statement a reference to the previous practice of screening stools in patients at York Hill. To see if you could identify what the sort of current flora of the gut was and how predictive it was. I think it was her reference. Excuse me if I've got that wrong. But I just don't know the literature to say that if you try to screen people's gut or you take throat swabs or skin swabs, I just don't know how predictive that is of subsequently developing an invasive infection. There must be a literature somewhere, but it's rather removed from my expertise, I'm afraid.
So your point is that if there's been patient-to-patient transmission or patient to surface and surface to patient or something of that kind, that still involves patient number 2 or 3 or whatever picking up that infection from the environment.
Yes, because I mean, whilst nothing is perfect, it represents a failure of the precautions that we try to take, which is hand washing and cleaning and unnecessary patient contact, perhaps,
As you pointed out, you deal with other organisms rather more shortly for the reasons you've just explained. Can I just ask you about Enterobacter, because you've got a little more narrative on that than on some of the others, which appears at page 139. And this may be the point you're trying to make about how much difference there is between the CNR authors and the HAD authors, because you say early on there, HAD seemed to play down the risk of hospital-acquired infections due to Enterobacter. And although you say, well, there are studies that show that it's possible.
Yes, I mean, rightly or wrongly, our impression was that there was a sense in which there was an assumption that Enterobacter is an endogenously acquired infection, and I think the first point we're making here is that actually there are studies that show it's clearly in the environment and that it can infect patients, and that the link with the environment has been established, so that was the first point. I mean, there is a much more complicated area about Enterobacter, which I feel slightly cautious about engaging with, but perhaps you might give me the opportunity to do that, because it really, or unless you want to talk about it under whole genome sequencing, because a lot of play has been made in evidence given that if you have an isolate of a bacterium called Enterobacter cloacae and you submit it to whole genome sequencing, you may decide it's not Enterobacter cloacae, you may be another subset of Enterobacter. And the difficulty I have is that, as a clinician, rather than a microbiologist or a molecular geneticist, as a clinician, if the microbiology department tells me that a patient has got an infection with Enterobacter cloacae, I understand that concept, and with the assistance of the microbiologist, I know what I need to do in terms of how to treat that patient. For us then now to be asked to consider that Enterobacter cloacae isn't necessarily Enterobacter cloacae, but it could be one of a number of different subsets, is something that actually doesn't really terribly well inform clinical practice. because over the years we've called Enterobacter cloacae, and merely using the data from whole genome sequencing to say, well, there's a whole load of different subtypes there, doesn't affect the fact that we treat them all the same. And I don't know, I can't even surmise. I don't know whether there is adequate information to say that one subtype of Enterobacter cloacae is more pathogenic than another subtype. And I suspect that that data doesn't exist in a clinically relevant setting. I also suspect that in 10 years' time, the microbiologists may well have subdivided Enterobacter cloacae into clinically relevant separate species that as clinicians faced with infections, you might take a slightly different approach to. But currently, I feel that the fragmentation of the Enterobacter family is whilst one has to take note of the evidence for it, doesn't actually help the clinical scenario.
Because you still treat what you have been advised by its present.
I don't know whether there's any grounds for doing any different than that. And it would be, it'd be interesting to talk to Professor Hawkey about it, but
So to that extent, the debate, if it's a debate about whether it is or is not the precise name when it's further analysed, doesn't at the moment impinge on clinical practice. Is that really the point you're trying to make?
it doesn't impinge on clinical practice. The question then is whether it should impinge on the identification of the proof of a relation to a source, which I think is probably the point that Professor Hawkey would want to make more forcefully.
So if you're doing the idea of trying to find a genetically indistinguishable piece of material, both in sample and in test, you might have to look at a different label other than Enterobacter cloacae.
Well, I think I would revert to Professor Wilcox. We've discussed this on a number of occasions and did so during the preparation of our rebuttal. Our belief is that bacteria exist in the environment in a number of subspecies, and the merely you identify one and not another doesn't necessarily exclude the presence of the other, as it were.
Yes.
But perhaps I'm sliding a little further away from the point you were trying to make.
Not at all. That's a very helpful, Professor. I was proposing to move on from Enterobacter at this point, unless my Lord wishes to.
No.
Thank you. If we go then on to, this is just, I'm just trying now to illustrate the way you've prepared the document. If we go on to page 140, we pick up on Pseudomonas, and largely what you say there is, doesn't seem to be much disagreement, because HAD say most important bacterium when considering colonization of hospital water systems, which can then lead to infection in susceptible patients, and you agree with that?
Yes, I mean it's a clear focus of concern and a lot of remediation.
Yeah. Now the next one is, I always get this pronunciation wrong.
Acinetobacter.
Yeah, now, did I understand that the point that you were making there was that the behavior, that may be the wrong word, but I think you know what I mean, of that particular organism may be associated with resistance to drying?
Yes, so that it
in a way that others don't.
Yes, so it can
feature.
persist on a dry surface, whereas others, so for example, sink traps are always wet. There's always residual water in a sink trap. But Acinetobacter, I understand, can exist on a surface that's been cleaned and dried. And you
Right.
look at the surface and there's no water there. But and I was using it, and I hadn't realised we'd quoted it actually, but I was using it as an example of the subtleties, the nuances of difference in the behaviour of these bacteria. And this is a particular characteristic, and I'm sure microbiologists could tell you far more than I could possibly say about these different groups of types of drugs of bugs.
So if we go on just in this section briefly to go to 142, when we have Stenotrophomonas. Now, what I was picking up from paragraph 3.5 of your rebuttal was perhaps a difference in emphasis in the words used by HAD and the words used by you. Am I right in doing that?
Yeah, yes, I think you're absolutely right. The emphasis, I think we were just bristling slightly at the terminology relatively rarely causes infections. And I think what we saw in the case note review is that it was one of the more prominent causes of the infections. We were just making the point, which I'm quite sure Professor Hawkey would agree with, that actually Stenotrophomonas multifilia is increasingly recognized as an important pathogen, particularly in immunocompromised patients. And we did this very simple literature search just to say there's a whole range of literature out there. I mean, possibly we didn't need to say that, but it exists.
So at that point, you stopped bristling and moved on to another point.
Yeah, we did.
Your next heading is just what you might describe as others. Now, I wanted to go on page 143 to ask you a couple of things. First of all, I think from watching the other evidence in this case, in particular the evidence of Dr. Drumright, you had picked up perhaps a question from Mr. McIntosh which you felt didn't quite correctly explain what was and what was not in the CNR case note review, which was something to do with the Cupravitis from 2016 and 1 Microbacterium chelonae. Is that right?
Well, I mean, what has become clearly established in all that I've read about this inquiry is that Greater Glasgow and Clyde acknowledge that there are two infections that have irrevocably been linked to the environment through molecular typing, genetic typing, one of which is a Cupravitis and the other is a Mycobacterium chelonae. We mention them both in the case note review for different reasons. The Cupravitis patient, and it caused us some confusion, I think, when we were doing our work, was back in 2016. This patient was not in the case note review because it wasn't a hematology oncology patient. I believe it was a renal patient. And we did do a certain amount of searching around to try and ascertain that. Now, I have seen, even in, Kathleen, is it Harvey Wood's the statement that the patient was attributed to being a hematology oncology, but that patient does not belong to the case note review. It doesn't negate the importance of recognizing that Cupravitis has been found in the environment, and the frequency with which it's found in water has been discussed, I know, and that an infection in a patient has been linked to the water supply. So essentially we make that point just to try and get rid of it because it doesn't, in a sense, belong to us. The second is a case of Mycobacterium chelonae. There were 3 patients with Mycobacterium chelonae included in the case note review with 4 infections between them because one of the patients had what was counted as a second infection. But because of the nature of this organism, I mean, I personally, I suspect it was because it was never eradicated. It was a very difficult infection to eradicate. We were told by NHS Glasgow and Clyde that they had whole genome sequencing evidence that this case linked to an environmental sample. But we could never identify that information from the information they gave us. So that the point we made in our report was that we would have clearly labeled this case as definitely related to the environment, but we didn't, because we hadn't seen at first hand the evidence for that linkage. But it seems to me that everyone accepts that that linkage is there.
So this was you adopting one might describe as a rigorous approach. You were only labeling things that came from the material that you were able to analyze and discuss.
Yes, I think it would have been, actually, I would use a word as strongly as irresponsible for us to say there is a definite relationship to the environment in an individual patient when we ourselves had not seen the data. Personally, I don't dispute the statement, but I hadn't seen the data and I wasn't prepared to write it down.
Now, earlier in your evidence today, you mentioned Mycobacterium chelonae in the context, I think, of the fact that it's not listed by the HAD authors.
Yes.
You found that surprising. Why did you find that surprising?
Well, I found it surprising for two reasons. One is because some atypical mycobacterium are considered to be potentially within an environmentally acquired group of infections. And secondly, because there were 3 patients and 4 infections identified in the case note review. And I just wondered why they chose not to comment even. I mean, there's no mention of it anywhere.
I think we've had other evidence. I think it may be the point you made a minute or two ago that this particular organism is challenging to treat. I
Yes.
just use that as a euphemism.
Yes.
Is that correct?
Yes, it requires. I mean, I have to say, I've never treated a case of this mycobacterium. It happens, but in my experience, it's unusual to have 3 cases in a series of patients would be most unusual in my experience. It requires very prolonged exposure to antibiotics.
Yeah.
Months of antibiotic exposure.
Thank you, Professor. Now, I think that takes us conveniently to a different chapter of your rebuttal. And the next chapter starts on page 144. And what you're doing there is you're looking at the HAD report challenges to the methodology that the CNR had used, and you summarize some of the points that you want to pick up on that page. And I think we can perhaps most easily take them as they come, rather than getting you to read through all of that now. So if we go to the first of these, which appears in detail on page 145, now, this seems to be focused around a discussion of the significance of the fact that some patients are at home, some patients at home during treatment, and what importance that had to the conclusions that you're able to reach as to source of infections. And I think as I understand it, the point you make in the rebuttal is that not all the references that HAD quoted were published at the time you did your work. But you thought that the selection was, well, as you put it, selective. But you accept that source it out with the hospital is a possibility.
Yeah, indeed it is. It has to be, and in fact, I hope we strengthened our position by pointing out that there is one patient in the case note review where we unequivocally said that the infection we believe to be related to the home environment, and indeed that was the conclusion of the clinical team. We found out subsequently who had been caring for that patient.
I was interested in the 2 points in the next paragraph on that page, the paragraph which starts, "We wish to point out." Can I just ask you the first one? You've probably picked up that there have been discussions over the relevance of pediatric hemato-oncology experience as compared to experience in adult hemato-oncology, and whether the two, as I say, we're just treating everybody the same, or whether there are significant differences. You could have mentioned that in passing at the start of paragraph, that none of the HAD authors has experience. Is this important in your view?
I mean, I do think it's important. I suppose at one level, and I think this is Dr. Agarwal said this in his evidence. He said, well, I know about infections in immunocompromised patients, and essentially we're looking at the rates of infections in populations of immunocompromised patients, and I don't need to know anything more than the number of those infections and the type of infections. I suppose I would argue, I would argue that has to be contextualized, because the children that predominantly made up the case note review were children with cancer or leukemias. There were, as I think we made clear, children with other forms of blood disease included within it, but nevertheless, and this is a very young population. The case note review points out that the median age for the diagnosis of the children included in the cohort was 3.5. And the median age at which the first infections occurred in that group of patients was still at around about the age of 5 or something. So this is a very young population. It's a characteristic of children's cancer work that a great number of the patients you work with are very young. Some of these patients are diagnosed at or soon after birth. Now, the ability to assess and clearly to manage very young patients is the essence of what pediatric care is about. And we have skills and experience that are relevant to understanding how, in this very specific setting, infection presents itself, is managed, and some of the consequences of the way in which you do manage them in terms of drug dosing and choice of drugs and so on. And I would argue that at the other end of life, people who are experienced in looking after elderly and fragile people have to have a similar but different set of skills that would allow them to do their job. So I think it is insufficient to say it doesn't matter that you don't have any insights. I mean, apart from the fact, and that the range of diseases that we treat in childhood cancer and blood diseases is not the same as in adults. It is a different world, there's no doubt about that.
Yeah, I think, and no doubt someone will correct me if I'm misremembering it, Professor Hockey said, well, the treatments are different. They're not simply small adults. If that's what he said, would you agree with that?
Yes, it's a very well-known, it's a very well-worn phrase. Children are small adults, and pediatricians used to say it a lot. And it's absolutely true. You can have you can have the same disease in children as in adults in relation to cancer or leukemia, but even when you do, it isn't necessarily treated with the same intensity. It's treated more intensively in young children, and the ability to push children in terms of intensity of treatment is probably greater than it is in the average adult population, or not necessarily with younger adults. But
Sorry, my fault. Could you just repeat that last point, Professor? I
well,
lost I lost
the point I'm making is that that you and I think I said it in relation to the quote about the Aitken study, which is about the meropenem, that yes, we do see acute myeloid leukemia, which was the nature of the population. We see acute myeloid leukemia in children. We don't see it that much. We see another kind of leukemia, acute lymphoblastic leukemia, more commonly. And although the approach to treatment is broadly similar, the intensity with which you can push young people with your chemotherapy is by and large greater. There's a resilience that we harness in young people to allow us to treat them relatively more intensely under some circumstances, and with good effect. So, for example, survival rates for the commonest kind of childhood leukemia are much greater than for the same disease when seen in an adult population. And there may be many factors, but one of the factors is that you can by and large deliver and sustain delivery of more intense treatment in young children than you could in someone even in their 30s or 40s.
Thank you.
Yeah, I just wanted to pick up a point which piqued my interest slightly, which you mentioned at the very end of your narrative on page 145, following a discussion about home acquired infections and so on and so forth. You say that the desire to maximize time for the patient to be at home is not merely for reasons of social benefit or family cohesion, but also because of the recognized risk of hospital-acquired infection. Now, that may sound slightly counterintuitive if you're thinking of people acquiring infections. The idea is, well, let's take them into a nice, sterile hospital environment, but you're making the point that some of it is the other way around.
I think it's well recognised that the worst place for patients to be is in hospital if they don't need to be there, and I think that drives all manner of healthcare initiatives. If you look across the piece, patients spend much shorter times in hospital now for many conditions than they did in the past. And one element of that, of course, is all about using facilities more efficiently. But underpinning it is also a recognition that being in hospital isn't necessarily the most healthy place to be. You are potentially exposed to more intrusive interventions. You are potentially exposed to more infections. And moreover, you're removed from the necessity to perhaps be as active as you should be when you're recovering from potentially serious illnesses and so on. So hospitals are important, but being out of hospital, I mean, home is generally a safer environment than a hospital.
Thank you. Now, you then go on 146 to explain some of the information that you had access to in order to carry out the task that you were doing, this Tableau software. And I don't think anything particularly turns on that for present purposes. And you go on to confirm that you considered the possibility of a source out with the hospital as well as hospital source. So I don't think I need to delay you on these, because I think you've made your point very clearly. I'm not sure I'll need to delay you much on the next point either, because we come on page 148 to what you've heading as the meropenem theory. Now, this is one of the matters that might be regarded as having moved on a bit since this document was drafted. But you indicate at the start of that section that you accept the general proposition that broad spectrum antibiotic use can create issues which lead to infections. That's not in itself in dispute, is it?
Not at all.
And then you pick up the reference to Stenotrophomonas, which you've already made here this morning. The point, as I understood it, that you were making at this stage was that the Aiken study, which you mentioned earlier today, which is mentioned and referenced in the course of page 148, and we see the bundle reference there. I don't think we need to look it up. You felt that as a document on which to form a conclusion had weaknesses in it. Is that right?
I thought it had substantial weaknesses, and I thought it was unfortunate that this particular reference was utilised in several points in the HAD document. It seemed to have acquired a substantial status when, if you read the paper, it has a number of weaknesses, some of which are recognised by the authors of the paper themselves. You know, I mean, it's good practice for authors of research papers to critique their homework by saying, what are the strengths and weaknesses of this paper? And they did that very nicely. And they pointed out, and I felt it was an inflation of value. I'm not saying that there's nothing there. I'm just saying that it has inflated value.
And I think what you did at the time when you prepared this rebuttal was you went and looked for other literature which might or might not be of assistance, and you set that out over the next few pages. And we've had other evidence about meropenem. We've had evidence about whether there was a shortage of other antibiotics which impacted on the availability of meropenem, did that, although that particular unit, and we've had evidence from Professor Gibson, who was in charge of the unit, essentially that the worldwide shortage didn't bother them because they were protected in a way that she explained. And you looked at the policies, is that right, as well, that were in place for prescription of antibiotics?
Yes.
And I think you deal with that on page 151 near the foot. Now, you then set out what that policy was. And I don't think I need to take you to the reference to the worldwide shortage because we've already dealt with that through other witnesses, including, fairness, Professor Hockey. But just, I suppose, to complete the meropenem story, I think you're aware we've had evidence from Professor Gibson with some evidence in the Harvey Wood graphs about meropenem usage per incident. But you were looking at this theory at the time of increased meropenem usage. Can you just explain what it was you were doing on page 152 and what your conclusion was? Because you obviously decided to take a look at this in a particular way, and you end up with a table, and you say that near the foot of 152, the analysis shows no difference. Now, just help us to understand what the analysis was.
There's an unfortunate page break where the header of table 4.1 is at the bottom of 152, but the meat is on 153. So if we could see 153. So essentially what we did, we took the population of patients with Stenotrophomonas, which is the population of interest in terms of driving. The hypothesis is that meropenem usage drives the occurrence of this particular organism. As a control group of significant infection, we took the patients with Enterobacter, and these are patients' infection episodes within the case note review. And then we looked to see whether patients had received meropenem for whatever reason within 30 or 60 days prior to the diagnosis of either a Stenotrophomonas infection or an Enterobacter infection. Now, these are very small numbers, but we could only use the information we had in front of us. And I wasn't able to, we don't have a database of all antibiotics given to every patient in the case note review, but I could go back and look at the individual clinical synopsis that we had created for each of these patients to pull out this information. And essentially what you see on the table on page 153, if you look at the line that says S. multifilia, we had 18 records that we considered informative out of 23 records in total, and that's an important term. Informative meant that the records for the patient spanned the period we were looking at, because of course if the patient had an infection very early in their experience of the hospital, they wouldn't be eligible for this analysis. But essentially, did we have informative records? We did in 18 cases, and of those 18 cases, 5 had had prior experience of meropenem in the previous 30 days, and 13 hadn't. And if you look at the 60-day data, which is the right-hand side of the chart, there were 14 informative records, and 5 had had prior meropenem, and 9 hadn't in the 60 days prior to the diagnosis of the infection. And we repeated the same analysis in the line underneath for Enterobacter cloacae. You can see it's 4 versus 18 out of 22 in 30 days, and 5 versus 7 out of 12 in 60 days. Essentially, if you apply a simple statistical comparison test, a chi-squared test, it demonstrates there's absolutely no difference between these two populations in terms of their meropenem exposure. What does that tell us? Well, it doesn't tell us anything very much, except that in this very small analysis, there's no evidence that these patients had excessive exposure to meropenem, the patients who had Stenotrophomonas. So that was the best I could do with the data we'd got. I think if it had shown something differently, then perhaps we would have had to trim our narrative slightly differently.
Thank you.
That seems to demonstrate that if one has a hypothesis that infection rates are in some way driven by meropenem administration, there was a method available on the basis of available data to check that hypothesis.
Yes, and the literature that we looked at, and we didn't do a systematic review, as I was describing it a little while ago. The literature that we selected to look at essentially did that. I mean, all the other studies we looked at did the same thing. They just took a cohort of patients and looked back in their records and said, well, did these patients get exposed to meropenem or not? And then there was a question whether they had an effective control group to compare, because inevitably patients who get antibiotics like meropenem are pretty sick. So they're likely to have been exposed to many other antibiotics too.
Just before we move on to a different topic, I may need to come back to this later. In the course of very recent discussions, another antibiotic has cropped up, which has the shortened name of Cipro or Cipro.
Ciprofloxacin. Yes, it was.
Ciprofloxacin.
I heard Professor Hawkey discuss it yesterday.
Now, at this stage, all I need to ask you is this. When you were doing your work, did you have any indication that an issue over the prescription of ciprofloxacin was driving any of the results you were seeing?
No, and I think it would have been difficult for us to do that because, let me try and explain why. Because in the case note review, we were able to interrogate the clinical story of patients who had had an infection. And we knew, therefore, that some patients had received prophylactic ciprofloxacin because it became a policy decision of the unit to give ciprofloxacin to patients. I think in 2018 or so, because of the concern about infections. What we didn't have is a parallel group of patients from the same unit who'd received ciprofloxacin who didn't get an infection to put them into the case note review. So that actually we weren't in a position to make a comparison. What we do know is that the use of prophylactic antibiotics, particularly using ciprofloxacin, is variable across different units. It is more typically seen in patients who are intensively treated, particularly patients undergoing stem cell transplantation. It is known to be associated, the use of aggressive antibiotic therapy is known to be associated with driving in general the risk of antibiotic resistance. Whether ciprofloxacin selectively drives a population of a specific bacterium, I have no idea. Whereas there is a hypothesis that meropenem drives the appearance of Stenotrophomonas. I just don't know. I've never encountered a reference. The generality of the risk is well known, and I think the department at Greater Glasgow and Clyde took very seriously the decision to use ciprofloxacin prophylaxis, and that there was an evaluation at some point, sometime afterwards, about whether it should continue or whether it was now safe or appropriate to stop giving it to patients. And I know it caused some concern to parents too.
Yeah, I've tried to find something that might assist us on this. You may remember that at one point, Ms. Harvey-Wood and Dr. Peters had produced a series of graphs, and one of these graphs showed antibiotic use, which peaked and so on and so forth, and also showed in a dotted line the presence of organisms resistant to the particular antibiotic running at a much lower level on the graph. Now, one of the antibiotics on that graph was Cipro, and unfortunately for us, the line that's supposed to represent the presence of resistant organisms simply runs along the zero. So there's nothing much to interrogate because it's not moving.
Right.
So I'm unable to put to you at this point anything that would assist further. But it's possible I might have to come back to this later, at which point, or this might be an appropriate point to break.
I wonder I could just take the opportunity, Professor, to make sure that I've understood what you were telling us about Enterobacter. Might be helpful if we could put on the screen Bundle 44, Volume 1, page 26. This is the part in the HAD report, which in part of Chapter 3, which includes the description of the Enterobacter and the SPP. The SPP, if I'm remembering correctly,
Species.
is the abbreviation for species.
Yes.
Right. Now, we see in the second line that Enterobacter cloacae has a complex taxonomy. And we see, if we go into the second paragraph, looking at second sentence, we have when outbreaks of Enterobacter cloacae involving environmental sources occur, molecular typing using WGS usually demonstrates a clear cluster of a specific strain type. Well,
Yes.
so be it. Now, if I understood what you were saying was that, well, it may very well be that Enterobacter has maybe many strains, but it's not of particular interest to the clinician because the same, as far as is known, the same antibiotic response would appear to have the same impact on, assuming there are a variety of strains, that variety of strains. Now, point one, did I understand what you were saying correctly?
Yes, yeah, you absolutely did, my lord. I mean, perhaps if you look at the first paragraph under section 3.1.2, following after the sentence where it says complex taxonomy, it says the next most common species encountered in hospitals is Enterobacter haumachi, which used to be classified as Enterobacter cloacae. And I think, you know, what this is telling us is that they've broken off, as it were, a separate subset, but they're still part of the same family. So from the clinical perspective, the label Enterobacter species is probably correct. I don't want to conflate that with the potential for identifying source of infection by using matched whole genome sequencing, which clearly seems to be important and is a separate argument. And so I
Yes.
hope I didn't conflate them.
Right. That is, at risk of simplification, that is what I picked up from what you were saying. The identifying a particular strain might have a utility for forensic purposes. If by that I mean if one is particularly focusing on cause and effect, it doesn't necessarily have an impact on clinical practice. Now, again, did I get that right?
Absolutely.
Now, my second question is, was there an additional point you were wishing to make?
Well, I think it's essentially further down that page when they refer to, and this was the publication by Nurjadi, which was discussed with Professor Hawkey yesterday.
Yes.
About 7 or 8 lines from the bottom, it says sequence typing of all Enterobacter cloacae isolates across the hospital revealed many ST types, and then it gives a list of ST numbers. And so what it is demonstrating is that there is, in a sense, a diffusion of genetically identifiable subtypes of Enterobacter cloacae. And you know, your use of the word forensic is helpful in that setting. Is that if you're trying to identify a source for an infection, knowing its genetic characteristics is very helpful. And we've never denied that. All we're saying is that it's not something that's practicable in real world time.
Right, but there was no additional point that I missed.
No.
Well, as proposed by Mr. Connell, we'll take our coffee break now, and if I could ask you to be back for 5 to 12.
Yes, certainly. Thank you very much.
Mr. Con.
Right, Lord. Professor, ciprofloxacin, just to try and see if we can finish what little we can do on this at the moment. Correct what I'm saying if it's wrong. You think you may have an issue, which may relate to the environment. You may then decide to prescribe something like ciprofloxacin as a prophylaxis to deal with that issue. Is that the kind of scenario that you understand arose?
I think it's the scenario that applied here, but in standard clinical practice, ciprofloxacin is also used as prophylaxis for very high-risk patients, without there necessarily being any particular reason to be concerned about the environment.
Yeah, but your understanding was that what applied here was it applied, as it were, reactively to there being an issue.
It was, and it was applied. I understood it to be given to all patients. I don't know the detail.
Thank you. Well, we've tried to find material, but we've only managed to find material from 2019 when we're in a different ward, so I won't take you to that. Let me see if we can deal with another few points reasonably shortly. Page 154. The heading here is defining the population. Your point, if I'm picking it up correctly, seems to be, well, we set out what we were looking at quite clearly in the overview report. Is that right?
Yes, I mean, absolutely. And then it did occur to me that he perhaps wanted to know what all the other infections that we didn't consider in the overview report had been counted. I mean, I don't know exactly.
But you had a protocol that you were working to.
Yes, I mean, I felt that, you know, we described the population, we described the number of infections of each individual infections that were found in the population.
And when you say it was a predefined protocol?
Well, it was a protocol that essentially preceded the formation of the case note review team. I mean, we were presented with the protocol, we had an opportunity to comment on it, but we didn't make any changes to it.
Thank you. So that was part of the setting up of what became the case
Yes.
note review.
Yes.
Thank you. Now you pick up the Mycobacterium shaloni point. I needn't ask you about that at this stage. And then there's some discussion about clusters. This is perhaps just referring back to something you said earlier. You were talking about routes of transmission and ways in which a patient may be exposed. And you said you'd set it out later. Now, would I be right in thinking that that's what you do at the top of page 156?
Yes, I think yeah, that's exactly it. We tried just here to summarize opportunities for environmental contamination, I suppose, and how infection could get into patients.
Yeah.
Directly into the bloodstream, principally. Yeah.
But defining in any individual case precisely where and what may be more difficult.
Yeah, absolutely. Yeah.
Now, I want to ask you a question. I've been asked to ask you a question about something on the next page, page 157. On 157, you describe concerns about the quality of data and about data from whole genome sequencing. And you make there a comment about an electronic database. You say Despite over 5 years of experience in investigation of outbreaks of GNE bacteria and concerns about the hospital environment, NHS GGC had not established an electronic database of microbiological typing results. And you say that's a criticism you stand by. Now, I think I'm right in understanding that that point about a database made its way into the recommendations of the case note review. Is that?
I think it's there, yes.
Yeah. I don't think we need to dig it out and put it up on the screen. I can just read you briefly what it says. Recommendation 10. NHS GGC must continue to develop a comprehensive and searchable database that allows details of microbiology reference laboratory reports to be compared between samples of the same bacteria obtained from different patients or environmental sites. And then the second part is the system for integrating microbiology reference laboratory reports into the patient microbiology record needs to be reviewed and strengthened. And similarly, the system for ensuring that microbiology reference lab information is available to and used by the IMT process, including the investigation of clusters and outbreaks, needs to be reviewed and strengthened. Just pausing there. Why was this important enough to put it in the recommendation?
I think one of our frustrations was that we recognized that attempts had been made to obtain a genetic analysis of samples from patient infections earlier in the era of the case note review by sending specimens from the laboratory in Glasgow to the reference laboratory in Colindale in London. The results of those findings were sometimes, but not always, noted in the microbiology records of the patient. But there didn't appear to be a place at which knowledge of those results could be identified. So you couldn't go to a database and say, give me all the genetic analysis of infections for patients on Ward 2A in 2019. It seemed to us that at a relatively simple level, just having a database that said this patient had this infection on this date, which was either sent to the labs in Colindale or more latterly dealt with internally in Glasgow, and that there had been an attempt made to look at whole genome sequencing, or perhaps one of them earlier, less comprehensive techniques, would have been extraordinarily helpful. And the database ideally would also have recorded whether samples that were positive for environmental bacteria had been subject to the same types of investigation and identified by date and by site. And so you could then interrogate a database and say, give me all the environmental isolates that have been subject to whole genome sequencing in 2019. Now, the results of genome sequencing, as we've seen from the paper, are very complicated, and so I don't think you could put the data into the database. What you could do is essentially create a register of what those samples were available. What we found in the case note review is we asked for this material, and there was no consistent way of knowing whether we were getting all the material or some of the material, whether some of it was missing or whether it related in any way to environmental sampling. It was a bit murky.
Now, one of the issues the inquiry has looked at from time to time is whether the recommendations of various bodies, including the case note review, have been complied with. What I've been asked to do is to put certain characteristics of what has been said to have been created to you and ask you whether that meets what you had envisaged in your recommendation. The characteristics being that the database includes only PDF copies of microbiology reference laboratory results. To access the report and results, you have to open and read the document, and the database therefore does not, it is suggested, permit easy searching of results. Now, is that the kind of resulting database that you had in mind when you formulated these recommendations?
Yes, I just perhaps to reiterate what I think we would have found helpful, and I'm suggesting that NHS GGC would find helpful moving forward, as would I think any hospital, is that you have a database that is able to say this test was done on this date, and gives you an indication of where you find the result. Because, as I just said, the data is complicated, and you can't readily put it you can't summarize it in a readily accessible form in a simple spreadsheet, for example. I understand the challenge of PDF reports. That's how they were provided. I'm not saying that you necessarily have to translate what's on the PDF report into the spreadsheet, but there wasn't at the time, and I hope there is now, a database you can go to which you can say, well, was there a report on that date? In which case, I can then go to an index and look it up.
Right. So if, assuming that what Mr. Connell just put to you was a criticism of what GGC has put in place, you would not regard that as a fair criticism?
No, I can understand the challenge. I mean, you can embed a PDF into a database. I don't think that's too difficult, but it does in the end become cumbersome. I think what we were suggesting is you must know what you've got. And I think our criticism was really focused on the fact that they didn't really know what they had, and it hadn't been consistently recorded in the patient's microbiology record.
I think I only have I have two questions to follow that. In the course of an earlier part of your answer, you talked about interrogating the database. Now, another way of putting that might be searching.
Yes.
If, in order to find out what's in any particular document, you have to find the PDF, open it, read it, and so on, might suggest interrogating or searching is challenging. Would you agree?
Well, I guess what I'm really suggesting is the first step is you have to be able to search for whether there is a report or not. And if you ascertain there's a report, then there's the possibility that you may have to go somewhere else to find it, to reveal its contents. The frustration we had was that we didn't feel that there was we weren't convinced that there was any way of being absolutely sure that all these reports were available, let alone what they contained.
I see. I can just ask you then a general question which follows on from my raising this point, which is, have you, and I mean, treat that as the CNR, had any opportunity of reviewing whether your recommendations have been complied with?
No, it was a point I raised. I can't remember formally or informally with the oversight board. I think we made the point when we completed our work that we would be interested to know whether our recommendations had been enacted or rejected. I mean, recommendations can be rejected, of course, but we've never heard anything. We've never received any feedback. That's perhaps not strictly true, because Greater Glasgow and Clyde did say in their rebuttal of our draft case note review report, well, we've already done some of these things, but clearly there were things that hadn't been done.
Thank you. Just if we could move on a little more quickly through some of the other issues, given where we've come to. 158, you pick up a general question about comparison of rates with other institutions and point out that you'd looked at some work by HPS, and I don't think I need to get you to read that, although your conclusion to the end of the section, which starts there, is that for your purposes, you weren't convinced that comparisons with other populations from other units was of much assistance in answering the question you'd been asked to answer.
No, I think on the next page there's a quote from the case note review, isn't there?
Right.
Yes. It said, our conclusions, we do not see that this report would provide a clear message of reassurance or concern about past events.
That was the HPS report.
That's the HPS report. So we're saying that we don't think that the report was either of reassurance, it generated either reassurance or concern to GGC at the time, and nor did we see it offered a clearly interpretable and favourable comparison with other children's hospitals, other Scottish children's hospitals. And, you know, so we read it with some interest, but we didn't think that it essentially pointed us in either direction. And we certainly hadn't been charged with doing a comparative piece of work, and I think that would have been quite challenging, but it could have been done, but we didn't pursue it further than looking at these data.
Maybe my fault. I'm just wondering, from Mr. Connell's question, and I may be wrong about this, I thought he was intending to explore the generality of whether comparing institutions with other institutions was useful for the purposes of the CNR report. However, if my recollection is correct, the quotation from the CNR report, which we see at 159, is your reflection, or the review group's reflection, on a specific study comparing 3 Scottish hospitals. And we see there that you didn't feel that that specific comparator exercise was either on the one hand reassuring or on the other hand concerning. Again, I'm sorry if that's a rather
No, absolutely. I understand your point. That, you know, you're absolutely right. This was a critique of that specific piece of work by HPS. In general terms, and I think my memory is that Mr. McIntosh took me through this last time. It was about the more general issues of comparative evaluation, comparisons with other children's hospitals, because when I gave evidence last time, we talked at a little bit of length about, well, were the comparisons that were, I think, chosen in Mr. Mukherjee's report the right kind of comparisons to make? And we talked about, well, you've got to make sure you've got the case mix similar, and some of the institutions that have been compared are not directly similar, some, you know, are, and so on. You need to take into consideration the factor of size, because small numbers distorts the situation. You would also, if you were doing it very carefully, want to look at issues to do with clinical practice and the use of antibiotics and so on. You know, there are many potential confounding issues in making comparisons between different institutions.
And in the document that we're looking at now, that's your rebuttal to the HAD report. You're responding to, I think, a comment in the HAD report, an adverse comment on the CNR report, is that you did not.
That we didn't do it.
You didn't do it.
We didn't do it, and our rebuttal is, well, we didn't do it, but there were some data which we looked at, although we didn't find them particularly helpful.
Thank you. Sorry, Mr. Connell.
And just to complete the narrative, what you then go on to do is to point out that there was another review which looked in comparisons with other pediatric hospitals in comparison in Scotland, and advised, you know, use caution when interpreting these results. And you then reach a conclusion on page 160 of this document. So this is your final response, which is comparisons of populations from different units offer limited assistance in responding to the question asked of the CNR, which you then specify.
Yes, I think that's the position that we would maintain. I think just for completeness, the reference to the further document, I think essentially still deals with the the same three hospitals, Glasgow, Edinburgh, and Aberdeen.
Yes. Yes. Well, let's see if we can move on again. Page 161, we turn on to a chapter headed Water. I don't want to take you through all of this. There's a lot of quotation from the HAD report. For instance, on page 161, you set out a piece of narrative from the HAD report about regression contamination and other associated issues with which you agree. Top of page 162. And then you think you have described a little more contentious statement on 162, particularly perhaps the latter part of the quoted paragraph, which is that it should be remembered that although one can find a source in a hospital environment of potentially pathogenic bacteria without a route of transmission and a portal of entry into the patient, these sources are of little consequence. And you describe that as a bit odd.
Well, I think essentially we're reiterating what we've already said, that it says here, but at the end of the second paragraph, there are multiple potential ways in which bacteria may be transmitted and cause infection. Perhaps it was a slightly tetchy tone, but I think we'd already dealt with that earlier in our document.
Yes, because the point being made in the HAD report as well, you can find the bacteria, but unless you can find a way in which it can get to the patient, it doesn't matter. You're saying, well, there are lots of ways.
Yeah, there
Is that a
are
reasonable
lots of
summary?
ways, and I think we for good measure we threw in the illustration on the next page, which just describes. I mean, this actually relates to care homes, but nevertheless, it describes the cycle of infection transmission.
And I think just beneath that, we start to get to a point which is perhaps a little clearer now than it was a few days ago of the who is claiming what debate. Are you claiming everything's environmental? Someone else claiming nothing is environmental. Now, neither of these is correct. And because you say, well, they're not necessarily the dominant source, but they are a source. Sinks are a clear source of gram-negative bacteria.
Yes.
Right. Well, let's move on to 164. This starts to touch on the question of testing. One of the issues, as you probably gathered from listening to the evidence, Professor, is that there's no real debate that the quantity and nature of testing changed dramatically from 2018 onwards once these issues emerged. And we find on 164 the heading, what if there was widespread contamination of the hospital water system? Now, I'm not going to get into a debate with you about the meaning of the word contamination, on which there are varying views. But you quote a section of the HAD report, which says, in our experience, problems of increased rates of infection caused by bacteria capable of coming from an environmental source are identified when intensive testing of water is undertaken when an outbreak is suspected, rather than from routine or prospective testing. Now, that might, I suppose, depend on the level and extent of the routine and prospective testing. We've heard a lot about much increased testing levels now. But taking it as referencing past, you just say, well, you agree, and that's what you thought was happening here.
Well, yes. I mean, I think we're saying. I mean, I think the point we're making is essentially GGC clearly suspected there was a problem, and they took the mitigation action they did, but earlier in the year of the case note review, there really wasn't very much testing going on,
Yes.
and I think that's been established.
Yeah.
You know, I mean,
Well, I think I had the word probably yesterday, sporadic, to reference some of the testing, but the details are all laid out in other
Well,
documents.
it wasn't just sporadic. It wasn't sporadic it wasn't just sporadic in time. It was relatively few in number too.
Thank you. Now, on 165, we're starting to edge towards the whole genome sequencing proving a negative topic. And you introduce halfway down 165 the needle in the haystack. Now, analogies can be dangerous things, particularly in the wrong hands, which might be mine. But I suppose if you imagine the haystack in which you are searching for the needle, if you put your hand in and something jabs you and you bring it out, lo and behold, it's a needle, everybody's happy. So that's the theoretical positive result. If you put your hand into the haystack in 3 or 4 random places and you don't find a needle, can you conclude whether the needle is there? Is that the point?
Yes, I think Mark Wilcox's Mark Wilcox's analogy. I think we're absolutely aligned with him on the use of the analogy, in that the absence of the finding doesn't negate the possibility that it's there. I mean, I think that's the shortest way to describe a lot of what's written here and has been discussed in other places.
But I was trying to see other places where this had been discussed, and might put this statement to you, see whether you agree. This was Dr. Chaput, who said that what you find in a biofilm sample tells you nothing about what is in the biofilm 1 centimeter away from that sample, never mind further away. Does that sound something you would agree with?
I mean, I can accept the premise. I mean, I don't have the background to challenge it. I mean, I'm not entirely clear what the relevance of the statement is, because what you find in the biofilm still matters.
Well, indeed, but it may not tell you what environmental bacteria are in the next centimeter.
No, absolutely.
Or in the next centimeter or a foot away.
No, and this was rehearsed in, I think, a conversation that took place yesterday about Pseudomonas not being, the finding of low counts of Pseudomonas don't tell you that there isn't anything else there.
Yeah, I'll maybe come back to that point, but the point that you were making, where you say you're all aligned, and I have to keep reminding myself that this is a jointly produced document, is possibly just shortly summarized on page 166, about, it's in the 3rd paragraph which appears on that page, the paragraph starting, "We concur." Put simply, the absence of DNA-based typing links between microbes in the hospital environment and those causing patient infections does not exclude the possibility that the former is the source of the latter.
I mean, I think that remains our position.
And one of the challenges, presumably, is if you've got a problem, you try to work out where it might have come from in practice, and you think how you might deal with that, and that might lead you to take perhaps a number of interventions rather than simply one, depending on the nature of the potential issue. Would that be right?
Yes, I mean, I think if you've got a serious problem, then you do everything you can to mitigate it. I think it was illustrated in relation to an outbreak of some Enterobacter infections, and I don't remember the number, but the PAG IMT system looked at this and identified growth of bacteria, the same bacteria in drains, and cleaned the drains. Was this back in 16 or 17, something like that? I mean, it's referenced in I think there's a specific reference to it in the case note review. So we see that approach took place. What I don't know is whether those samples in the drains were matched with the samples in the patient.
The point, I think, as I understood as Dr. Chaput took, was, well, if you have interventions A, B, and C, and the problem goes away,
Yes.
I'm being oversimplistic,
Mhm.
but you understand my point. Well, first of all, you don't know which intervention. If there's cause and effect, you don't know which intervention has worked. Or it may be A and B or C and A. You just don't have that information. Is that the reality?
Yes, I mean, I think you're absolutely right. It is the reality, but I mean, if we take the case of Enterobacter in the drains, I mean, if you find Enterobacter in the drains, then you clean the drains. But you also don't ignore the fact that the potential for patient infection can come from poor hand washing. And, so I would have thought that if you have a problem with an infection on a ward, you treat what you might see as the most obvious reason for it, but you would, I think, in terms of good practice, also pay attention to ensuring that some of the basics of protection are also being carried out appropriately. So I think you can do, I mean, when you get to the point at which GGC, I mean, the point GGC were forced to consider, which is to comprehensively retreat the water system and eventually to decamp patients from a ward, then of course you're taking decisions that have far greater consequences. But you do have the ability to implement lower level interventions at the same time without any great cost, because you wouldn't necessarily want to unpick them anyway.
And then you have the reality that you don't, if you appear to solve the problem, you don't know what particular one of the solutions has worked.
That's true, but at the level we're talking about in terms of drains and hand washing, I don't think it matters. If you've solved the problem, that's good, because it's not just Enterobacter that could be in the drains; it could be something else, and so you actually, what you've done is you've moved forward in terms of protecting the patients that you're responsible for.
And I think you make the point, which we can, if need be, drag back to the haystack analysis, that if you're going to have this positive identification of source and patient, you may need very intensive sampling. So in the haystack analysis, you need to check pretty much every handful of that haystack.
Well, and I think some of the literature to which we refer in our rebuttal actually makes that point, that you do have to do. There was a sample from there was a study from the John Radcliffe Hospital in Oxford. Was it Halstead? It was referred to by Professor Hawkey yesterday, and it's also in our paper, talking about the identification of environmental contamination. And there was very intensive water sampling and I think possibly other environmental sampling. I mean, the lessons are there, and I mean, it's not a trivial burden to undertake, but if you're an organization that's faced with these challenges, then it would seem a sensible thing to do.
And again, just so we can reference where we've got to, 167, which follows immediately after the Halstead quotation that you've just mentioned, which, as you say, was discussed to some extent yesterday. you referenced the question of intensive sampling just before you turn to the next topic. Now, you go on to consider similar elements in the remainder of that chapter, and I suspect it will simply become repetitive if I take you to everything that you say, because we end up talking about meropenem again, which I don't particularly wish to do. So I think we'll try and move on to a different topic. You move past ventilation very rapidly because that wasn't something you evaluated as such. Is that right?
I think there are two things to say briefly about that. One is, I think we put in this report that we really didn't pay any attention to ventilation because in our initial informal discussions, we agreed that we didn't believe that ventilation per se had a tremendous impact on gram-negative environmental infection. And there's an argument that's been rehearsed, I think, about how much aerosolization can be affected by adequate ventilation. But I think everyone seems to agree if it is affected, it's a very small component. The second point, which we did put in the case note review, related to the cold beam technology. I think there is a bit of a dispute about whether chill beams are appropriate for this kind of environment. And there were certainly reports of condensation dripping from the chill beams, dust collection on the chill beams, essentially whether these just added to the potential wet risks of the environment in which the children were cared for.
I think we know that the guidance on the use of chill beams in clinical areas has changed since the incident there, so we needn't pause too long on that. So on page 171, you have a heading, Water Analysis of Infection Rates and Data from QEUH and RHD.
Well,
you
that's
say,
we use their chapter titles.
Right. But I was just about to say that what you then immediately go on to say is, well, that's what the heading says, but what it actually does is slightly different, because you have an examination of testing for Pseudomonas aeruginosa, an epidemiological review of bacteremia, and whole genome sequencing in sort of 3 separate chapters. Now, I think I can probably move past the first of these reasonably quickly. Testing for Pseudomonas aeruginosa. The quotation you have from the HAD report says that inspection of results for this particular organism should give a good indication as to whether there was extensive contamination of the water system, particularly in high risk areas. And your immediate response is, well, there's no real evidence to support the proposition that the results for one organism tell you much other than about that organism. Now, I have another quotation this time from, I think, for my colleagues 153A of the transcript from Dr. Chaput, when she was asked, does testing for Pseudomonas aeruginosa tell you nothing about other organisms? And she agreed with that proposition. Do you agree with that proposition?
So she said that testing for Pseudomonas
testing doesn't tell you anything about other organisms.
I think that's the point we're making.
Yeah, and I think you actually say that at the end of the second paragraph under that subheading, where you say that the levels of that organism in water tell us about one bacterium and not about others. And then there's some discussion about the levels of testing and how TVCs are sometimes used as a means of gauging levels of bacterium in water.
I'm familiar with all these concepts, but there's some distance from my practice.
Thank you. So what you've done in the end of this section of your discussion is you've gone to your overview report, and at the foot of 172, you've quoted from your overview report and said there did not appear to be a systematic water sampling process in place or a consistent water system related response to clusters of infection. And then there's some discussion about how communications went and whether results were always available and so on and so forth. And you were a bit concerned about all of that given what was going on. Is that right? Fair?
Perhaps could we go to the next page?
Yes, 173.
Thank you very much. Well, yes, I mean, this is a very specific point that we were told by staff within GGC that they had requested access to water sampling data but had not been given it, which struck us as slightly unusual. Well, very unusual. I mean, we couldn't understand why anyone would withhold the use of data which is available in the organization, particularly when it is people involved in the microbiology and infection prevention control service.
And your conclusion immediately follows that quotation from the overview report, which you say you stand by, that you conclude that the levels of this organism reported by HAD have little or no bearing on the likelihood of water contamination by other gram-negative bacteria relevant to your case series. That's your position, is it?
Yeah, that's our position. Yeah.
Now, in the next section of the report, you deal with a number of issues, including inter-institution comparison, and so on and so forth. And I suspect, again, we'll become repetitive if we go back to all of that, particularly given the way some of the issues that we're talking about have moved on. Can I just ask you, just so we're understanding the rebuttal properly, to go to page 178. Just so the chair and others understand what you were looking at here and why you took the trouble to look at it. What was the issue here? It is pediatrics and adults being looked at together.
Yes, I understand now. Well, I think if you go back to the previous page,
177, please.
The second to bottom paragraph where it says Hawkey et al. I think this is the relevant paragraph because essentially what we're saying here is that Professor Hawkey and colleagues provided no data on the size of the patient populations from which their incidence data derive. And what we're really pointing out is that there would have been very many more adults in their analysis than there were children. There would have been a substantial difference in the size of the two populations. And that's because there are more adults than children in our population. And also there is more malignant disease, more cancer and leukemia in adults than there are in children. So if you look at the table on the next page, 178, what we're really doing something is very basic. We're just totting up the number of environmentally relevant bacteria in the adult series, counting only the data available, counting the data for the adults from 2013 to 2023. And if we just take the example of Pseudomonas there, third from the bottom of the table. There were 32 episodes of Pseudomonas bacteremia in the adult population. And in the next column, there were 8 episodes of Pseudomonas aeruginosa in the pediatric data, but we only extracted this from the same era as the case note review. That compared with the 9 patients we found in the case note review. And I have pointed out there are some minor numerical discrepancies between the two. But the point we're making here is that 8 out of a rather small number of children may be actually quite significant compared to 32 out of a vastly larger population of adults. But that data is not available to us. If you then go to Stefan, so there's a 4-fold difference in the adult and pediatric Pseudomonas infections. Is there a 4-fold difference in the size of the population? I don't know. We'd have to get the data, but I'm sure there would be. If you go to Stenotrophomonas in this table, what you see is that in the adult data, albeit this is over a slightly longer period of years, and we should perhaps have brought it back, but there were 45 Stenotrophomonas infections in the adult population, and there were 22 in the childhood population. That's a factor of 2. Now, it strikes me that that's just in terms of the size of the relevant populations, that's a relative excess of Stenotrophomonas in the pediatric population. And I think we argue the same for Enterobacter, 24 versus 36. So the sentence at the end of that paragraph underneath the table is, this observation of itself would have been useful for Professor Orchid to have discerned and explored. It's just a very simple comparison. It's difficult to know whether it's significant. My strong feeling is it's highly significant.
And the significance is the disproportionate, what you see as the disproportionate numbers
Well,
in
I would
pediatrics.
suggest that this data implies that there are a disproportionately greater number of children experiencing Enterobacter and Stenotrophomonas infections than there were adults. But to do that, you need the size of the population. You need to know the number of patients who are exposed to the risk.
Now, while we've got numbers, I think you know by now that the charting of infection numbers as between York Hill and the Queen Elizabeth by HAD authors have had further discussions, has now led to some new charts which weren't available to you at the time that you wrote this rebuttal. So at various points you are rebutting suggestions made in the original report, which perhaps have slightly moved on. So what I'd now like to just do is go, at least briefly, to Bundle 44, Volume 5, at page 50. Now, first of all, what I gather there's a point about presentation, which I understand you want to make, so let's allow you to do that first. If we look at page 50, this is environmental pediatric BSI, and for the sake of argument, it shows a rise from somewhere around 2016 up to 2018-ish and then down again. And I'm not going to get into the epidemiological definitions of what that is. Now, if we look at page 51, we then see what, at least at first glance, seems to be a very similar chart, non-environmental bloodstream infections. But am I right in understanding, Professor, that the point here is that the scales are different? So although at first glance on a sheet of paper of A4 size, they look similar-ish in general appearance, the scales are different on the left-hand axis. Is that right?
Is it possible to have the 2 pages projected side by side, or is that feasible? Or
No idea. No. I'm being told.
No? Okay.
There's a technical challenge which I'm.
Okay, well, I mean,
However, it can't be beyond us to achieve that one way or the other.
Well,
Maybe
I think the
simply by
professor has a hard copy.
printing off copies.
well, I have the hard copy in front of me.
He has
so
the hard copy there.
I just
so-
thought perhaps it would be helpful to talk about it together, but I'm very happy to talk about it without it being projected together. So,
Right, well, we'll see how we progress on that. But
Okay,
but I can
thank
see
you.
the importance of being able to.
well, the point I want to make is that this is
Let's call one page 50 and one page 51, and that will keep us right.
the two F3, which is the
Okay.
previous graph,
Right.
which is environmental pediatric BSI. The y-axis gives a predicted rate of up to 25.
Mhm.
And we see the peak
And so you
very
see,
roughly just under the 10 mark. Is
yes,
that right?
but if you go to the non-environmental
Mhm.
pediatric BSI in figure 2F4, the y-axis goes to 40. And the difficulty with the GAM analysis is that the statistical significance of what it tells you is about the pink line moving out of the range of the blue line, but it's also a very visual way of displaying data. And so that the visual comparison between these charts would lend you to believe that the frequency of environmental and non-environmental bloodstream infections is broadly the same, because the lumps, the humps look the same size.
Yeah,
But if you-
whereas the hump on 2F4 goes up. Now,
Yes, but
I'm
if
not
you-
intended to be precise,
you-
but say
if you-
22 or something
if
like
you
that.
plotted them on the same axis, you would see visually that the number of non-environmental BSIs is rather substantially greater than environmental BSI, and that may be an important point in terms of understanding what's going on here, because predominantly non-environmental bloodstream infections in this type of population are contributed to by gram-positive organisms, so what we call staphylococci. There are different types of staphylococci, but coagulase negative staphylococci and Staphylococcus aureus. Coagulase negative staphylococci in particular account for a very substantial number of bloodstream infections in children. And it has a bearing on understanding why the work done by the GGC team, the HemOnc team on CLABSI improvement matters, because the work that's done on central line associated bloodstream infections is largely targeted towards reducing the occurrence of gram-positive infections, because staphylococci of various forms are typically found on the skin and very classically affect the line site and sometimes the track under which the catheter flows under the skin. And so if you have a lot of those infections, which you do, and you implement measures to reduce it, you'll see a reduction. Because I understood in discussion of these curves, people were saying, well, you've shown there was a peak in environmental bacteremia, but why is there also a peak in non-environmental bacteremia? Now, it's a little difficult to understand that, except if you look at the non-environmental figure 2F4, you see that it's never near zero. It's always. I mean, central line associated infections from staphylococci are always with us, and that's what this data shows. That the dots are never along the bottom. Whereas with the environmental ones, there are times when the dots run along the bottom of the graph. And that's because environmental bacteremia is so much less common than non-environmental. But the work of the CLABSI group would undoubtedly have had a significant impact on the non-environmental bacteria, and it would have a relatively less great impact on the environmental.
I think you, in the narrative of your own report, and we'll just leave these graphs up if we may for the moment. Just take it from me, you mentioned the CLABSI group, i.e. the Quality Improvement Group work
Yes.
in 2017, which led to what you describe as a highly creditable diminution in the rates of line infections to a standard that was regarded as very good, and in which you specifically mentioned in your overview report. Is that right?
Yeah, absolutely, absolutely. I mean, they did have a problem. It was quite clear. They had high rates, I think as high as 6 per 1,000 line days, and which would be considered very high, but they drove it down to under 1, which is internationally very competitive. But that didn't diminish the fact that there was a problem with, I don't think you can say that got rid of all your environmental infections. But there were other things going on, of course, which was the treatment of the water and moving the patients out of the environment.
So your first point to us is that if we're looking at these documents, we need to remember that the scales are quite significantly different, so that the peak of
I think visually, I think it would just,
they look the same, but
they do look the same, but I think I think if you saw them plotted on the same y-axis, they would look different, and that I think that would assist in understanding what the challenge was. And it, you know, and it's not quite clear why that wasn't done for the children, because it was done for the adults. All the adults are on the same. Oh, possibly they're not actually. I've just seen got that wrong. But anyway, I think it's.
I'm assuming, but I could be wrong about this, Professor. The reason that the y-axis goes up to 40 in the non-environmental pediatrics is that it's the result of the nature of the data. It's in order to accommodate the scatter.
You're right that the values do go up to that point, but the difference between, if you measure the difference between 0 and 5 and 10 on the y-axis, it's further apart on the environmentals than the non-environmentals. So it will distort the visual effect of the curve.
I would find it quite useful if you just talked me through the point again, because I have to confess I had not thought about this before. I think I've got the visual presentation point that if you have a greater or lesser y-axis, a trend can appear one way or the other. I think I get the potential for being misled. Now, what additional observations would you make?
Well, I don't think it changes the message of the shape of the curve where there is a rise and a fall. And it doesn't change the information which both these diagrams show, which is where the pink line moves out away from the blue line, and therefore you know there is some deviation. But what it does, I think, do is it obscures the fact that non-environmental bloodstream infections are much more common than environmental bloodstream infections. And I think, therefore, potentially it affects the way we think about, well, how come they both reduced, and was it for the same reason? And I'm suggesting that actually the impact of the CLABSI quality improvement group is clearly transmitted into the reduction of the non-environmentals. But the change in the environmentals, I believe, comes from the work done to the water supply and the relocation of patients. That would be my interpretation.
Right. Thank you.
When you wrote your rebuttal, you weren't looking at these graphs.
No, unfortunately, we only saw these in the last
you were looking at different graphs, but just for the record, on page 179 of your rebuttal, you highlight the quality improvement group from 2017, the reduction that you've just mentioned, and then you say, well, yes, very good, but as you put it in the middle paragraph, we caution that although central line care can reduce the incidence of gram-negative BSI, its principal benefit is in driving down the frequency of staphylococcal line site infection. Is that the point you were trying to make a little earlier?
Yes.
Thank you. I think this might be as good a point as any to pause, Lord, subject to anything that the Lord wishes to take.
No. We'll take our lunch break now, Professor, and if I could ask you to be back for 2 o'clock.
Certainly. Thank you very much.
Please stand.